All right, we're going to go ahead and get started. My name is Dr. Luke Haynes, physical therapist. This is dry needling for the low back pain and piriformis syndrome, part of the Haynes method of neuromuscular dry needling offered through the Haynes PT Institute. So I want to go ahead and get started with the program here. So dry needling for the low back pain and piriformis syndrome. Again, welcome to the webinar. We're going to take some time today to talk about what the low back pain and piriformis protocol is, who it would be beneficial for, what diagnosis and conditions, and why and how the protocol was developed. We'll take a look at some three-dimensional anatomy to determine exactly where the low back pain and piriformis protocol is applied to those specific structures. We'll briefly review the precautions associated with dry needling. We'll then review the relevant surface anatomy and look at the dry needling procedures for low back pain and piriformis. During the webinar, if you have questions, you can enter them in the Q&A section on the bottom of your screen, and I'll try to address as many of those questions as time allows. And at the conclusion of this webinar, I will make this content available online for those who wish to view the information again. So what patient conditions would benefit from the low back pain and piriformis protocol? Well, quite a few actually. That is a challenging area to properly diagnose and provide a good treatment approach for. But anything in the lumbo-sacral junction, the sacroiliitis, a little bit more lateral at the lumbo-sacral pelvic junction, that posterior hip phenomenon, our term sciatica, traditional piriformis syndrome, further laterally, the greater trochanteric bursitis, iliotibial band syndrome. So back pain is among the most prescribed and treated pain complaint in the body. Dry needling has shown a significant improvement in the pain symptoms of low back pain and piriformis syndrome. The primary goal of treatment is to reduce muscular tension to decrease the radiating pain symptoms. There are some instances where we will use tissue mobilization to release impinged nerves, which can be a direct cause of low back pain. And in the lumbar spine, the biggest thing we look at there is the cluneal nerves, superior, medial, and inferior. We frequently use manual therapies to make an impact on a patient's pain presentation. As a neuromuscular approach, we can have that same type impact by utilizing dry needling to create that same outcome. I've reviewed a lot of research studies that claim varying results with the use of dry needling for low back pain and for piriformis. In some cases, the authors will describe the actual dry needling protocol by needle placement, and some will not. That is the hallmark of this approach, is that I want to show you and tell you what I've learned and where exactly we need to be placing needles in order to get our most optimal therapeutic outcome by dry needling. Again, I've developed these dry needling protocols, in this particular low back pain and piriformis, based on the location of the symptom complaint, the area of tissue inflammation, and the target tissue of symptom provocation. So the structures we'll be looking at needling, the multifidus, the longissimus, the lliocostalis, the interspinalis, the serratus posterior inferior, quadratus lumborum, the psoas major, the PSIS itself, the sacroiliac joint, Gluteus Maximus, Medius, Minimus, the TFL, the Piriformis, the deep hip rotators, the cluneal nerves, and then the latissimus dorsi and the internal external obliques and the transversus abdominis. So some general dry needling precautions to look at. The contraindications, non-consent from the patient, the first trimester of pregnancy, nipples, umbilicus, external genitalia, anyone dry needling in the cervical region, especially upper cervical, if there's a suspicion of Chiari malformation, or if there is actual radiographic imaging, imaging of any type indicating that that was a contraindication. Then anytime there's any sort of implanted electronic device, you wouldn't want to needle onto those structures themselves. Some relative contraindications for our surgical patients, any tissue that communicates with a surgical site, you want to wait 6 weeks on dry needling there. And then in local area, the direct surgical site itself at least 12 weeks, unless you have prior permission from the surgeon who did the surgery, just to avoid any complications related to infection. Some general precautions: needle aversion or phobia, if there's a person with significant cognitive impairment, if there's a communication barrier, any history of traumatic or spontaneous pneumothorax, if there's severe hyperalgesia or allodynia, a metal allergy, someone with an abnormal bleeding tendency, or vascular disease, or a compromised immune system. Again, these are precautions, not necessarily contraindications. And then additional precautions anywhere around the area of the breast implant, with especially in the spine issues, someone who's undergone a laminectomy or who has scoliosis or severe osteoporosis, that can have a significant impact when we're talking about our backdrop, which typically will be on the lamina of the spine itself. And obviously, if there's been a laminectomy, that all of a sudden that backdrop is not there, or if there's scoliosis and you have a rotation of the vertebra, then your elevation and your height or your depth of penetration will vary, and it can be fairly significant based on the curvature and the rotation of the vertebra in that regard. A little comment on perineural dry needling. It has become more prevalent when treating conditions in the extremities that include impingement of nerves such as carpal cubital tunnel syndrome, among others. The head, we also do some perineural dry needling there. Some entrapment syndromes that can, dry needling, especially for perineural, can be used to decrease that impingement and to facilitate some response back through the neural tissue itself. The peripheral mechanism for perineural dry needling is centered around decreasing the localized inflammation in the tissues that is causing the impingement. There's also a central desensitization that occurs, an interruption of the sensory afferents and the nociceptors that are signaling the pain response. There is unfortunately a sparsity of evidence concerning the mechanisms of perineural dry needling. Definitely more needs to be done in that regard. Anecdotally, we are seeing good results with perineural dry needling. So a little on surface anatomy. So we jump down, and I'm not going to spend just tons of time here. Some of the key elements that we want to look at, if we want to identify S2, it's in line with the distal aspect of the PSIS. The S1 spinous process is just slightly cranial to there. You'll feel a drop off from S2 on to S1. And we move further, the spinous process of L5 will be a bony prominence. It feels almost like a pencil eraser, just cranial to S1. You can confirm L5 by applying a bouncing or a springing force using the ulnar side of the hand to the space between L5 and S1, and you'll notice an increased amount of motion at that junction, especially at L5. We move on to L4. L4 sits at the level of the iliac crest, and then you can follow the spinous processes cranially to identify L3, L2, and L1 and above into the thoracic spine. A little bit more on the palpation or the surface anatomy. In the pelvis itself, two main structures that we get concerned about. I guess there's more than that, but two critical areas we want to make sure that, one, that we hit, and two, that we don't hit. Piriformis, we can identify from a line from the PSIS out to the superior aspect of the greater trochanter, and then there's an inferior hipper line that is about a second half of the sacrum from the PSIS towards the coccyx itself, and that should outline the direct path of piriformis. Sciatic nerve is the one we want to miss, and it sits underneath the piriformis, and then as it gets out closer to the femoral head, then we're going to see it take an inferior target, and we'll actually run in between the ischial tuberosity and the proximal femur itself. So just keeping an eye on where we do and do not want to have our needle dropping for those structures. We can move further into that Again, possible problem areas and focus of treatment would be at the lumbo-sacral junction for sacroiliitis, the lumbo-sacral pelvic junction, which is extremely common, especially in older folks, people with OA and degenerative disc disease. Our typical complaint of sciatica with radiating symptoms, piriformis syndrome with a localized tender point and focus of discomfort. Greater trunk bursitis, a little bit more laterally, the IT band syndrome, which will be more down the lateral aspect of the femur. Then the cluneal nerves, again, both the superior, medial, and inferior. The challenge here is always determining the source and the location of the pain generation and determining what the proper needle application would be to properly treat that, to decrease that tenderness, that inflammation that's going on. So a quick look at some three-dimensional anatomy. I'm going to see if I can share to a different program here. All right, we're going to jump over into, this is a program is called Complete Anatomy. It's a really good piece of software. I would recommend, if you're going to be doing any dry needling at all, avail yourself of a good 3D model so that you know exactly where the tissues that you're trying to needle are in relative orientation to the body and their position on your treatment table. So this first one is the multifidus. You can tell multifidus as the primary spinal stabilizer, travels all the way up to C2 as an attachment, and then courses through the cervical, thoracic, and then lumbar spine, and its terminal insertion through the sacroiliac joint, even on down distally on the sacrum, and coming close to the coccyx itself. So multifidus covers a lot of area, and frequently with spine issues, multifidus will be one of the key elements of treatment that we're going to be looking at. So we look a little further. Now, let me bring this out. Multifidus. The next one we'll look at is longissimus. Longissimus is going to sit just posterior to multifidus. It's a little bit more superficial. It's got a very similar distal orientation. You can see it actually attaches maybe just a little bit further distally on the sacrum than did multifidus. However, it still has very similar attachment on the spine itself. It's just more superficial. Again, instead of laying on the lamina itself, its attachments are out on the transverse processes. And longissimus will have a broad depth, length of tissue as well, even further than multifidus, as it actually has an attachment and its cervical component up onto the mastoid process. So that's longissimus. We'll move on to the lliocostalis, which will be a good landmark for some other structures. As you can tell, it sits just a little bit lateral from multifidus and longissimus. Its origin on the iliac crest itself, and then down to the PSIS, and a little bit further distally there. It's going to sit a little bit laterally, and there is, whatever you're palpating for this muscle, there will be a clear demarcation between the muscles of the trunk, the obliques, and so forth. And as you come in to hit onto the lliocostalis, it will move a little bit further laterally, the further up in the thoracic spine that it goes, but it does provide some good landmark. We'll talk a little bit later about the quadratus lumborum and its origin just at the lateral border of lliocostalis. We will move from there. Let's go ahead and go to, let me move through here. Let's find our, also a really important structure. Nothing really happens at the PSIS, except the PSIS seems to be a central repository, if you will, of inflammation. So if we're dealing with some issues of the gluteals, Max Mead men coming over, especially Max and Mead as they're traveling, and their attachment in this area. A lot of inflammation tends to happen right here. If there's a sacroiliac joint issue, also tend to see a lot of problems, a lot of tenderness, just localized inflammation at the PSIS. And even with the multifidus and the longissimus, as it comes down in its attachment, especially if there's a lot of tense tissue, it does tend to pull on the connective tissue around the PSIS. And so PSIS is almost always one that is included in my scope with dry needling for lumbar and lumbopelvic pain and dysfunction. We'll move on to the, let's go deep first. Let's go to the psoas major. From a posterior aspect, the psoas major sits fairly far anterior. So if you look at it from the side, it almost, well, at the lower lumbar, L4, L5, it does actually ride anterior to the vertebral column. And that's where you'll find that we're going to needle this thing. Further proximally, it does come a little bit higher, a little bit more posterior on the vertebral column itself, but it stays fairly medial in relation to the second muscle, which is the QL, which is kind of hidden right here. And so let's drop down and take a look at QL. We had talked about the lliocostalis. So it's a lateral border, sits just at the medial border of QL. So when we identify it, we're going to find the lateral border of lliocostalis, and then that gives us our identifier to move up laterally and superiorly to make sure that we can identify QL. It is fairly superficial, especially in relation to the psoas, as the psoas comes more anterior, actually as it comes all the way anterior and it attaches onto the femur itself. So QL is also a key player in the low back pain. So let's move on down to the gluteals. Let's see here. Start with Gluteus Maximus. Here we can see its origin on the medialmost aspect of the iliac crest, almost to the PSIS, and then its further origin down to onto the sacrum, even some fibers onto the coccyx, where it attaches over to the both the iliotibial band as it comes distally off of the iliac crest, and then on its femoral attachment as well. So a really big, powerful muscle in the Gluteus Maximus. We'll talk about this in a bit. There's a central location, almost a merger of Gluteus Maximus, Medius, Minimus, and Piriformis that seems to stay centered right about the location of the arrow for my mouse. And whenever we're dry needling anything back in this area, that is a centralized point, which is my location for Gluteus Maximus. That seems to get very good response out of that location right there. So if I have a lot of things going on and I have a patient that's phobic or apprehensive about needling, if I only get one needle, I'm going to drop that needle right there and get a really good response from that. So let's move from Gluteus Maximus to Medius. In Gluteus Medius, again, it's going to sit just a little bit further lateral. It has a smaller footprint, and it definitely has a femoral attachment more on the posterior aspect, giving it its characteristic movements or actions that it's responsible for. The shaded muscle, which we'll talk about, is Gluteus Minimus, and you can tell, given its location, kind of helps define why Gluteus Medius and then Gluteus Minimus has a little bit different action in reference to their rotation properties. So Gluteus Medius, take a quick look at Gluteus Minimus. Again, even a smaller footprint yet, where it attaches. Again, powerful muscle, and definitely one worth a look at whenever we're determining neuromuscular dysfunction. And so from there, we'll move to, let's go ahead and look at the tensor fascia lata, and then we'll catch the piriformis. No, that's not it. Where did my TFL go? I may not have included TFL. I'm not seeing it here. So the TFL, it's not, I don't have the picture pulled up on that, but TFL is going to come off the anterior aspect of the iliac crest from mid spot right here over almost to the ASIS, and the IT band itself, iliotibial tract, will be the posterior aspect, and that will form the IT band as it runs all the way to Gertie's tubercle on the tibia. And then the tensor fascia lata itself will actually be on the anterior aspect of the IT band in this general area. And so let's move on to the piriformis and take a quick look at that. The piriformis has its attachment on the superior aspect of the femur, the greater trochanter. And then it also attaches, or its origin is on the anterior aspect of the sacrum. So lots of pain, lots of issues related to the piriformis. There are times that the piriformis is overdiagnosed, in my opinion. Frequently, a person feeling pain and getting a diagnosis of piriformis syndrome is probably dealing more with a little bit of a glute med, even a glute max response in this area that we talked about, whereas a merger of all four of the rotators, the big rotators of the hip. And so, but piriformis, really nice location, can be needled both laterally and medially. Medially, you have to be cautious with your depth, simply because location of the sciatic nerve as it runs underneath piriformis to exit out and travel in between the ischial tuberosity and the lesser trochanter of the femur. So we'll move on to talk briefly about, let's talk about the sacroiliac joint. A lot of pain and inflammation involved in the SI joint in a case of a person dealing with possibly an innominate rotation, upslip, downslip, or just some instability. Really, really good response from dry needling directly into the SI joint. It's a case where can drop 2 to 3 needles in this area. There is a very thick, fibrous connection between the ilium and the sacrum. So you'll feel almost a bony-like sensation as you drop that needle. You're going to have to push through that to get down into the depth of that SI joint. And so the SI joint, really nice location for the dry needling. Let's see if I can find one last thing here. Well, two more things. So another key issue is the smaller hip rotators, distal to the piriformis, gemellus, and the obturators, as well as quadratus femoris, with this sciatic nerve traveling between piriformis and the superior gemelli. Important to needle those if you do suspect an impingement in this location, as opposed to a true foraminal problem further proximally. And so really nice approach to needling through those rotators there. And then lastly, let's look just briefly at the cluneal nerves. There are some situations where we tend to have some isolated pain in these areas. The cluneal nerves can become entrapped as they exit the fascial layer between the iliac crest and then the thick, dense thoracolumbar fascia. The superior cluneals, the medial cluneals, a little bit different issue, but further on the Gluteus Maximus itself, as the inferior cluneal nerve branches off. It's less likely, but it can become impinged right here and give us this medial pain on the inferior part of the gluteus maximus. So let me switch back here and jump back onto this. All right, so we move on to, and bear with me one second, I want to make sure that I'm properly sharing here. Here we go. All right, so now we are. So we just talked about the 3D anatomy. Let's move on to the treatment. And we're going to demonstrate this with a video of an actual treatment of all of these muscles momentarily. But longissimus and multifidus in the lumbar spine will be needled as a single unit. It's really not possible or necessary to try to differentiate those two. When I teach my level 1 dry needling course, my starting point is always at L4, simply because it's a landmark that we can easily identify, being level with the iliac crest. And so that same needle placement, which will be 1 finger breadth superior or 1 finger breadth lateral from the spinous process, can be used at L4, L5, 3, 2, 1, wherever in the lumbar spine that we want to dry needle this. I just used L4 because we've got some really nice landmark, and a new student, new practitioner with dry needling really needs to get comfortable with the idea of palpating the structures so that they have a full awareness of what the location is of their needle placement. And so that's where we look at for multifidus and longissimus. For lliocostalis, we're going to grasp the lateral border, and we'll demonstrate that in the video of the lliocostalis, and then we will needle, and again, it's at L4, from the lateral aspect, almost lateral to medial, just a little bit, maybe 15 to 20 degree anterior angulation towards the table to make sure we get through the bulk of that tissue. I do have written down here that there is a backdrop on the thoracic lamina. More often than not, that is not the case. More often than not, there's no backdrop, especially if you're using a 30 millimeter needle. You're going to get through the lliocostalis, maybe into some of the tissue of the multifidus, or more likely the longissimus. But there probably won't be a backdrop here. The interspinalis, I do needle this from time to time if I've got a patient that just does not seem to be responding to treatment. How functionally relevant is this to movement or to pain and associated dysfunction? Probably not all that significant, but it is a muscle grouping that can be needled, and we do see some results from that from time to time. This is the only area in the spine where you will actually needle from an inferior to superior approach. Given that, we're going to use a smaller needle that's going to be less than 20 millimeters in order to effectively dry needle those two muscles. Moving down into what I term the pelvic rotator cuff. Here, our gluteus maximus, we're going to have a spot, we're going to identify the greater trochanter and the PSIS. We'll split that in half, and at a midpoint, we will needle down to the ilium with angulation perpendicular to the ilium itself. Gluteus medius, I'm going to use the IT band as my reference. I'm going to follow it all the way up to the iliac crest. I'm going to move 3 finger breadths posterior along the iliac crest, and then I'm going to drop inferiorly 2 to 3 finger breadths to land into the belly of gluteus medius. Again, my needle depth will be to the ilium, so I will have a backdrop, and that can be a 40 to 60 millimeter needle. Previously on the gluteus maximus, depending on your patient's body girth and morphology and habitus, I mentioned in that slide that it would be, let's see if I can go back to it, 40 to 60 plus millimeters. And at times that is true. The needle lengths that I'm giving here are for safety. There are some patients that I will use literally a 12.5 centimeter needle, which is 7 to 8 inches in length. And that needle length still doesn't provide adequate depth to reach my backdrop. So patient habitus is definitely important to determine the length of needle use. The lengths here definitely are for safety. Moving on to gluteus minimus, again, I'm going to locate my superior aspect of the greater trochanter and follow the IT band all the way up to the iliac crest. I'm going to find my midpoint in between those two structures, and from a completely lateral to medial direction, I will needle through the IT band and through the muscle of Gluteus Minimus to land up with a backdrop onto the iliofemoral ligament. Gluteus Minimus is the deepest of the three gluteals, and it takes some depth to get to that. For tensor fascia lata, I'm going to have a very similar location that I'm looking for as far as needling. However, with TFL, we have the IT band in this area right here, and that is the piece that runs distally to Gertie's tubercle. However, the TFL itself sits a little bit more anterior, so instead of a lateral to medial approach, we're going to go from posterior to anterior. So they're going to be laying in prone, and we're going to needle down towards the table. We'll use our fingers on the anterior aspect to appreciate our depth so that we don't run the needle through the skin out the other side. Piriformis, again, the greater trochanter is our landmark. We're going to go a finger breadth, maybe 2 finger breadths superior from the superior aspect of the greater troch. And then we're going to move medially 2 finger breadths. And again, a note on finger breadths. When we talk about finger breadths, thumb breadths, palm breadths, this is all in relation to the patient's anatomy. So I'm a big guy. My finger breadths would definitely be different than a smaller person. So it's your patient, it's your subject's fingers or thumbs or palms that you want to use when you're making these measurements. And so, and again, 1 up, 2 across, and then we'll needle down through piriformis to land onto the ischiofemoral ligament. And then the gemellis, the obturators, and quadratus femoris, we're going to move, again, superior aspect of the greater troch. We're going to move 2 finger breadths medially, and then we're going to drop, and we're going to needle in a redirection approach. We don't discuss at this level the specifics of how to do that redirection. However, what it basically means is we're not going to retract the needle all the way. We're going to drop it into superior gemellus first. We're going to retract a little. We're going to move the skin tissue, and we're going to do that all the way down until our needle ends up landing in quadratus femoris. We talked a little bit about latissimus and the internal external obliques, transversus abdominis. Because these structures do have attachment into the thoracolumbar fascia, which is part of that lower unit down onto the sacrum, we want to look at those to make sure that those are not contributing to some sort of lumbo-sacral, lumbo-pelvic dysfunction. So we may find that we do need to come needle the latissimus. For the QL and the psoas major, again, we talked about finding that lateral border of the inner, just drew a blank, lliocostalis. So at that lateral border of the lliocostalis, as you can see, that is also the medial border of QL. QL sits just a little bit further anterior. So at that lateral border on the iliac crest, we're going to move 2 finger breadths more lateral, and then we're going to move 2 finger breadths superior. And that needle placement just completely posterior to anterior, 3 to 5 centimeters will give our depth, our location for dry needling into the QL and psoas major. For serratus posterior inferior, again, similar to other musculature, how clinically relevant is this muscle to pain and dysfunction? It's questionable. If we are going to be dry needling at the TL junction in multifidus, in longissimus, or in lliocostalis, we will needle into this muscle. If we decide we want to just isolate that, then all we have to do, anywhere from T11 to L2, we'll move 2 finger breadths lateral from the spinous process, and then drop the needle into that muscle. It is very superficial, so 2 to 3 centimeters is the most depth that we would need for that. Again, PSIS, all I'm going to do is I'm going to palpate for that structure, and using just a periosteal pecking, I'm going to find 2 to 3 locations onto there, and I may take 5 to 10 seconds of pecking onto that PSIS to get my inflammatory response to promote that healing phase with the PSIS. On an anterior approach with psoas and iliacus, at this point, unless you're an experienced dry needler, I would stay away from the anterior approach. Primarily iliacus and psoas can be found. Iliacus can be found superior to the inguinal ligament, probably best needled as far as safety, distal to it. And then psoas at its anterior approach would be 2 finger breadths lateral from the femoral artery. A lot of femoral structures in the femoral triangle right here. So I would, at this point, unless you've got significant experience with dry needling, I would probably stay with that posterior approach with psoas major and iliacus. For the transverse abdominis and the obliques, I would put my patient in the sideline position, and just superior to the iliac crest, I would use a lumbrical grip and squeeze those tissues together and then needle through those to elicit the change that I'm looking for there. All right, so let's move on to a little demo here on the dry needling of these primary structures. In the lumbar spine, for the longissimus and the multifidus, the patient is going to be here in the prone position. Needling will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4, the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process. It should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. For the lliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters, and there is no backdrop. What we're going to do is grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. For the PSIS, obviously, the patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient's habitus. Backdrop, obviously, is the PSIS. We're going to palpate the vertical length of the PSIS, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the PSIS. For the gluteus maximus, the patient is going to be in the prone position. The needle length here will be 40 to 60 plus millimeters. The backdrop is going to be on the ilium. We're going to locate a midpoint between the PSIS and the superior aspect of the greater trochanter. We're going to needle posterior to anterior with relative orientation to the ilium, using the ilium as a bony backdrop. Caution here for the sciatic nerve. Proper angulation of the needle perpendicular to the ilium will place the needle superior to the sciatic nerve.
And now we're good.
For the gluteus medius, the patient is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. The backdrop is going to be onto the ilium. We're going to palpate for the iliotibial band superior to the greater trochanter to the iliac crest. We're going to move 3 finger breadths posterior on the iliac crest, and then insert the needle 2 to 4 finger breadths inferior from the iliac crest into the muscle with an angulation into the muscle perpendicular to and using ilium as a backdrop. For the gluteus minimus, the patient again is going to be in the prone position. Needle length is 40 to 60 millimeters, and the backdrop is going to be onto iliofemoral ligament. We're going to palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. And we're going to insert a needle at a midpoint between the iliac crest and the trochanteric apex in a lateral to medial direction using the iliofemoral ligament as a backdrop. For the tensor fascia lata, or the TFL, patient again is in the prone position. Needle length here is 30 to 40 millimeters, and there's no backdrop. We'll palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. We'll grasp the anterior aspect of the TFL with the fingers and the posterior aspect of the IT band with the thumb. At the midpoint between the 2 bony landmarks, we'll insert the needle and advance posterior to anterior, medial to slightly lateral towards the table, using your fingers as a backdrop to determine adequate depth. For the piriformis, the patient again will be in the prone position. Needle length can be 30 to 50 millimeters. The backdrop here will be the ischiofemoral ligament. For the lateral attachment, we'll palpate for the superior aspect of the greater trochanter and locate its medial-most aspect. Needle insertion point is 2 finger breadths medial and 1 finger breadth superior, posterior to anterior using the ischiofemoral ligament as a backdrop. So what I want to look at is, after looking at specific dry needling of the specific structures, what really brings out a true treatment approach is when we start to group a lot of these pieces together. So let's say we want to look at a problem that we've identified to be at the lumbo-sacral junction. So we've got an L4-5, L5-S1 problem. We may find that the pain is located, which is their complaint, at that area. However, we may also find that if this has been a more chronic issue, that there's other areas of dysfunction involved as well. So what I do is break my treatment down into primary, secondary, and tertiary treatment locations. My first day of treatment will almost always be just treating the primary locations. So in the case of lumbo-sacral junction, my primary structures, which are pinpointed in red, are going to be the multifidus, the lliocostalis, longissimus, the PSIS, and the SI. Now, given the patients, if they're apprehensive, I may not even treat all of those at one time, but for a successful outcome, there are good odds that I will need to address that. If I'm not seeing what I'm wanting to see in the lumbo-sacral junction, my second approach, I may come in and go ahead and add our secondary structures, which would be the QL and the psoas, and that indicated with the white circle here. And then finally, still not seeing the results that I'm looking for, third day of treatment, I may jump out and go to my tertiary locations, which would be glute max, glute med, glute min, and even piriformis. And so it's a structured layer approach to to affect some change in the target structures, target tissues that you're seeing with complaints and problems, dysfunction with your patients. So let's look at a few more of these. So for sacroiliitis, my primary location, something is causing that dysfunction. So I find my primary location for sacroiliitis is I'm still going to drop into at L5, L4, L5, my multifidus, longissimus, and lliocostalis. You will find across a lot of these different protocols that we are going to be needling some very similar structures. In the case of sacroiliitis, if I'm not having any lateralization or radiation in my symptoms, then I'm not going to move out into the gluteals. But I will then, my secondary location would be to treat or dry needle into the interosseous sacroiliac ligament, and the posterior sacroiliac ligaments. So I'm going to get a lot of movement in here. In the coursework that I teach, this is included in the third course, dry needling all of the specific conditions, say for sacroiliitis. And we talk a little bit more about the needle placements in there. But the short version is any of this ligamentous structure, including here on the PSIS, which I include for sacroiliitis, would be a nice approach. And then tertiary, we're going to look at the iliolumbar ligament up higher, the sacral interspinous ligaments, and the sacral supraspinous ligaments. And together, that's my layered approach to sacroiliitis. Obviously, any sort of manual therapy of the SI joint would be appropriate. I'd never advocate that dry needling is the only treatment approach, but this is a nice place to get that acute inflammation down and under control. For the lumbosacral pelvic junction, which is, again, a lot of that similar pain at the lumbosacral area, but you also now start to have some radiation or some involvement in the tissues further laterally. This would be a little bit more of a chronic condition. Number one, we're going to do all of those needling locations at the lumbosacral junction, which would be multifidus, longissimus, lliocostalis, QL and psoas, glute, max, med, min, and then the sacroiliac area. Secondary locations would be those that we use for sacroiliitis, which would be the interspinous ligaments of the sacrum and then the posterior sacral ligaments themselves. And then lastly, our tertiary locations would be the pelvic rotator cuff muscles. So the deep rotators and IT band here. This would also be included actually with the muscles that we're doing on the primary. When we're talking about sciatica, which again is just kind of a garbage can term for a condition, but we're going to assume we have a significant amount of issue coming through both piriformis and radiating down the leg. Here, we're going to go ahead and hit the pelvic rotator cuff muscles again, the glutes. Piriformis is included in SIJ. But the secondary locations, again, all the structures that are accompanying part of the SI joint treatment. And then tertiary, and this picture is actually a little off. The SIJ should be, or the tertiary should be right here, and the secondary piriformis. So in this case, reverse the pink and the white pictures. I just put them in there backwards. So that would be my approach with sciatica. Piriformis syndrome, primary, always I'm going to go after the piriformis laterally first. I wouldn't recommend anyone dry needling the piriformis medially until you've had a significant number of needle sessions, and we're talking several hundred needling sessions before I'd go medial. You can get a great response laterally. But the second level with piriformis is I would drop down and catch the muscles of the deeper rotators. And then finally, tertiary, the greater trunk bursitis and the sciatic bursa of Gluteus Maximus. So some good needling approaches there for piriformis. For greater trunk bursitis, primary would be the trochanteric bursa of Gluteus Maximus and Minimus. And so there are two bursa. Two identified bursa, I think frequently we'll find it as one single bursa in most people. So we'll basically take that on a 30 to 45 degree angle from the lateralmost apex of the greater trochanter over its superior aspect and then towards the head of the femur itself. And then we can get in and we can do some twisting on the needle, some unidirectional or bi-directional rotation to get some tenting off of the needle and manipulate that bursa a little bit. Secondary, I would come in and catch the iliotibial band as it's coming right over because that's where it's going to get a lot of that pressure onto that bursa itself. And then finally, for the pelvic rotator cuff, the gluteals, and then piriformis and the smaller rotators. For the IT band primary, I'm going to hit the IT band and TFL. And for my secondary, we'll go ahead and hit Gluteus Medius and Minimus, which are intimately associated with the IT band itself. And then a tertiary location would be the pelvic rotator cuff, which part of it will be included in the secondary. And then the bursa, the Gluteus Maximus and Medius, since it will be receiving a lot of the pressure. So my primary, secondary, and then tertiary needling approaches there. For the cluneal nerves, and we've got superior and medial we can do together. One, I'm going to get right on the iliac crest, and I'm going to needle onto that. I might just peck on there. I might do some tenting to get a response. I would also come down into the muscular locations of glute max, distally, and then to longissimus multifidus more proximally. I might even try to get some response and mobilize that tissue to help decrease any sort of impingement there. And then finally, the tertiary locations would be the gluteals laterally to the greater trochanter. So getting a good response there. And then inferior, the primary is a neural location. It's just the junction of the medial and lateral hamstrings at the inferior aspect of the Gluteus Maximus and the inferior medial aspect of Gluteus Medius. We could also come up and do some proximal spinal segmental locations at S2, S3. And let's move on a little bit of the conversation about dosage and frequency, because that is always a really good question. And I've developed what my clinical approach, which seems to be fairly effective in determining how much, how often, and so forth. Most cases can be divided into 5 categories. Dosage and frequency is determined on their activity level, the chronicity of the condition, their response to treatment, and probably the most important factor is the compliance of a patient to a well-developed home exercise program. I'm a massive believer in dry needling as a treatment modality to address the first phase of healing. With that being said, it is only a modality, it is not the cure. The belief that it is such is false. Dry needling is needed as is any other modality to address a neuromuscular response to a biomechanical dysfunction. That dysfunction can only be addressed through a change in mechanical function, flexibility, and strength. When properly applied, however, dry needling can be the most effective tool that we have in our arsenal to address the phase 1 of healing, which is that inflammatory response. So we'll start with these 5 classifications. Number 1 is the athlete. Here, the person has no more comorbidities. It's a brand new issue that popped up. It's within the first 10 days of injury, and they've not had a significant deviation from strength or from their performance level. The frequency here of dry needling is going to be 1 to 3 sessions within the first 3 to 5 days. Their prognosis is excellent, and they will be able to resume normal training within 2 to 4 days. A second classification of the athlete is someone who has 1 or more comorbidities. Their issue has now moved to a subacute stage, and it's 14 plus days. There have begun to have some asymmetries in strength and in performance. Their frequency of dry needling should be 3 to 6 sessions within the first 1 to 3 weeks or 7 to 21 days. They have an excellent prognosis. They'll need 2 to 3 weeks of training to restore any asymmetries, and then they can resume their performance training. The second classification is just your average Joe or your weekend warrior. This person is in decent physical shape. They had some incident that resulted in a strain or an overuse injury of a localized muscle or group of muscles. The frequency of dry needling here, 1 to 3 sessions within 3 to 5 days. Again, an excellent prognosis. They will also need to adapt an ongoing HEP to address the mechanical deficit that set them up for the injury in the first place. And then we'll move to the third, which is the quick stick. This is your work colleague. This is someone who slept wrong, somebody that just needs a quick fix. The frequency here, obviously, it's a single session. This prognosis is only fair. And the reason that is they're going to have an underlying condition that will need compliance with an HEP to correct, but they won't be willing to accept this fact and be willing to do the work. There's a decent chance that this person will become the fourth classification, which is the procrastinator. The procrastinator, they have 1 to 3 comorbidities. They've been dealing with their pain and function complaint for several years. They're unable or unwilling to deal with the issue due to a variety of either valid or invalid reasons. Now they have decided to do something about their problem. Their frequency of dry needling is going to be 8 to 12 sessions within the first 30 days. The prognosis is good, but their success will depend on their compliance with the home exercise program. And then finally, we have the hard case. This person has multiple comorbidities. They're dealing with severe OA or DJD, DDD, other issues that require surgical intervention or other intervention that can't be done due to a medical or personal issue, such as they can't get cleared for surgery due to a pulmonary or cardiac issue. The frequency of dry needling here, I'm going to phase this in across 3 months. First 30 days, you're going to need 8 to 12 sessions. We're really going to have to work hard on getting that pain down and under control. The second 30 days, there's going to be another 4 to 8 sessions. By then, pain is reducing. It's not gone, but it's getting a little bit better. You're able to put in a little exercise with it, maybe some stretching. And then when you get to that third 30-day period, we're still going to be seeing this person either once a week or once every other week, and that will happen indefinitely beyond. The prognosis with these folks is fair. This is just a long-term maintenance case. Insurance for these may be an issue, and they may require cash pay program. The treatment will be required until the interventional clearance is obtained. This is basically non-pharmacological pain management. The dosage may have to be adjusted based on the patient's condition. Treatment should improve functional outcomes, but withdrawing or discharging the service will result in return to their prior condition. And there will be limited improvement with a progressive HEP. So I hope you've enjoyed what I've put together here today. This is an awful lot to cover in a simple hour of time, but I will get this out to everybody that registered for the webinar. I'm going to upload it to the website, and I'll email it out through our YouTube channel. If you would like to get this information or more, I will send that out to you. Just feel free to email me. I've got a web address down below, www.dryneedling.org. That'll take you straight to our webpage. We will have more upcoming webinars. I'm planning on one a month right now. The next one that's coming up is on July 7th, and that's going to be dry needling for tennis and golfer's elbow. And so quite a few more that you can see throughout the remainder of this year. If you want more information, you can reach me through the information here online, through the Facebook page, my email, through the website, or through the Instagram channel. And if you have any questions, please feel free to reach out and let me know.